All right, let's jump right into this explainer by stepping straight onto the wards. I want you to imagine you're the physician taking charge of a really critical patient scenario. As undergraduate medical graduates getting ready for those internal medicine university exams, mastering acute renal failure or acute kidney injury is absolutely non-negotiable. It is a high-stakes clinical emergency, and your ability to confidently manage it, well, that's what will save lives and, of course, guarantee you ace those boards.
Picture this. You're on the wards, maybe it's your very first day as an intern. A patient's labs come back, and boom, that serum creatinine is climbing. What is your very first move? We are going to walk through the precise evidence-based orders you need to write, drawing directly from the gold standard medical texts.
Here is our roadmap for today's ward round. We'll be hitting management priorities, volume management, drug dose alterations, diet and nutrition, clinical monitoring, and finally, indications for dialysis.
Starting off with Section 1, Management Priorities. Okay, take a look at this flow chart. It literally anchors your entire diagnostic algorithm. When that creatinine spikes, we can't just guess, right? You have to systematically differentiate between three main categories. Is it prerenal volume depletion? Is it an intrinsic renal parenchymal disease, like acute tubular necrosis? Or is it a post-renal obstruction? Your specific therapy depends entirely on identifying the correct pathway here. If you skip this step, you're going to end up treating the completely wrong disease.
Moving on to Section 2, Volume Management. Assessing fluid status is your immediate next step, and it's a huge focus on exams. A critical differentiator to remember is this precise dichotomy. You are basically looking at two opposite extremes. You're either aggressively resuscitating a depleted pre-renal patient with balanced crystalloids, like normal saline or Ringer's lactate to restore perfusion, or you are fighting severe fluid overload in an intrinsic AKI patient using strict salt restriction and high-dose loop diuretics. You absolutely must assess their volume status before writing that fluid order. So, let's say your patient is finally euvolemic. How do you keep them there? You must decisively match their daily fluid intake to their daily urine output, and then add exactly 500 milliliters per day. Why 500 milliliters? That is the magic number to cover their insensible fluid losses. Think water loss through the skin and the respiratory tract. Seriously, write that number down. Examiners absolutely love to ask it.
All right, Section 3, Drug Dose Alterations. Reviewing medications is your next big task. And this sequence right here, it's a board-tested goldmine. You've got to stop the physiological insults first. That means hunting down and stopping nephrotoxic agents, especially NSAIDs. Why NSAIDs? Because they inhibit vasodilatory prostaglandins, which causes afferent arteriolar vasoconstriction and completely tanks your glomerular filtration rate. You also need to hold ACE inhibitors or ARBs if the patient is hyperkalemic, and you do all of this before you even start calculating new maintenance doses. When reviewing the specific interventions required, pay special attention to the drug dosing guidelines at the bottom of this table. It points out a massive clinical trap. During an acute kidney injury, serum creatinine actually overestimates true renal function. Because it's not a steady state, the changes in creatinine lag behind the actual drop in the filtration rate. So adjusting doses during acute failure is incredibly tricky and requires really vigilant, daily reassessment. Next up, Section 4. Dietary and nutritional modifications. Establishing metabolic control is absolutely essential. The failing kidneys simply cannot excrete electrolytes, so you have to strictly control them through diet. You restrict sodium to dodge pulmonary edema, but more importantly, and underline this in your mind, you have got to limit potassium. Never forget this. Hyperkalemia is the leading cause of death in acute renal failure. One single hospital tray packed with potassium could trigger a fatal cardiac arrhythmia. No joke. If your patient isn't on dialysis, you need to restrict their protein intake to about 40 grams per day. The idea here is to reduce the generation of nitrogenous wastes, which cuts down on those toxic symptoms associated with uremia, while still giving them just enough protein to prevent severe malnutrition. But there's a catch. To actually enforce that strict protein restriction safely, you have to prevent the body from breaking down its own muscles. You suppress endogenous protein catabolism by maximizing their overall energy intake, pumping in 20 to 30 kilocalories per kilogram every day, primarily through carbohydrates and fats. This is what keeps them out of a negative nitrogen balance. Section 5. Clinical and laboratory monitoring. Tracking progress is how we know if our plan is working. Now, if you see this table on the wards or in an USCI station, you must instantly recognize these indices. They're your diagnostic proof. A fractional excretion of sodium, or FeNA, of less than 1%, with a high specific gravity and a BUN to creatinine ratio greater than 20:1, that proves the tubules are intact and actively conserving sodium and water. It's purely prerenal. But if the FeNA is high and the specific gravity is fixed at 1.010, yeah, the tubules are officially necrotic. You are looking at acute tubular necrosis. Every single morning, your clinical radar needs to be locked onto these daily metrics. Track the urine output, watch the BUN and creatinine, check for hyperkalemia like clockwork. These values will dictate whether your conservative medical management is actually doing the trick, or if your patient is silently slipping into a life-threatening biochemical disaster.
And finally, Section 6, Indications for Acute Dialysis.
We must recognize the absolute limits of medical management. When do you call for backup? Take a mental screenshot of these criteria right now. Print them in your brain. These are the strict, absolute indications for initiating urgent renal replacement therapy, dialysis, when all your previous orders have failed. Severe acidosis with a pH under 7.1, potassium dangerously over 6.5 despite therapy, fluid overload that's completely laughing at your diuretics, anuria for over 12 hours, or any serious complication of uremia. I'll leave you with this provocative thought to carry into your exams in your future practice. What if your patient suddenly develops a pericardial friction rub on day 3? Are you ready to call the emergency dialysis team? You better be. Recognizing that a new friction rub means your uremic pericarditis has set in changes absolutely everything. It means your conservative management has reached its limit, and your rapid response to call for dialysis will be the exact thing that saves their life. Keep studying hard, trust your structured approach, and you are going to absolutely crush